Today's episode is very special. I'm joined by a person I deeply admire, one of the India's top urologists, Dr. Anant Kumar, chairman of urology, transplant, and robotic surgeries at Max Saket Hospital, New Delhi. With over 40 years of experience and thousands of successful urological surgeries, Dr. Anant Kumar is the one of the pioneers in his field, not only in India, but globally. Thank you for joining me today,
Thank
Dr.
you,
Anant
thank
Kumar.
you.
So today I would like to ask you about this field that is evolving in this medical industry. It's a robotic surgeries. As far as I did the research, that I learned that you are the one of the first in India who started the robotic surgeries in urology. So tell me about your experience. How did it start? How did you come up to this new field?
Yeah, the robotic surgery in fact started in America around 2002, 2003. It started by one of my friend, Professor Mani Menon in Detroit. He was the pioneer of robotic surgery in the world. And I had opportunity to visit his center, watch him, how the things are evolving, how he was struggling to establish the robotic program. And finally, he was the one of the most successful robotic surgeon in the world, who taught many robotic surgeons who are now big name in robotic surgery. So when we came back to India, we tried to bring the robotic science in India, but the robot cost was very expensive. Each robot was costing almost 15 crores of rupees, which was too expensive for India to afford it.
At that time.
But slowly I convinced the management and they bought the first XI robot in India in Max Hospital. And then we started doing the robotic surgery. And at that time, most of the robotic surgery we were doing mainly for the prostate cancer, bladder cancer, kidney cancer, and some of the reconstructive surgery like pyeloplasty, ureteric implant, auto augmentation, neobladder reconstruction, allele conduit formation. So these procedures we were doing. As our hand set in, then we thought that why not give this minimally invasive surgery benefit to our transplant patient. And I was the one who have been removing kidney laparoscopically since 1998, the first one to do it in India. So our donors were getting laparoscopic donor nephrectomy. Kidney was retrieved from very small incision and our donors very, very happy. And slowly this culture has percolated all across the country and more people started doing laparoscopic donor nephrectomy. But we were still doing the transplant surgery by open method where we used to give big incision and then patient used to get lot of pain, morbidity, and they take long time to recover. And especially in the obese patient, operation used to become difficult because most of the obese patients are diabetic also and they get wound infection, wound dressing, secondary closure. So there was a lot of morbidity associated with obesity and problem.
Because of large incision, right?
Large incision, diabetes, immunosuppression, seroma collection, fat necrosis. So they used to get a lot of morbidity.
Yeah.
And at that time in Chicago, it was established that if you do the robotic surgery in obese patient, the results will be very good and these morbidity can be reduced.
Recovery is going to be speed
And
up.
recovery would be. So around 2016, we started doing the robotic kidney transplantation, where kidney is dropped with a small phalansteal incision into the abdomen and the whole procedure is done robotically. Now the incision is 6 centimeter, so that all the morbidity has cut down, recovery is good, patient wound infection is gone, and they also don't develop lymphocyte. And slowly we realized that this is one of the very good operation for obese patient because it takes away all the wound related morbidity. And it is also good in young females because incision is phalansteal, incision is hidden.
Cosmetically.
It is cosmetically better. In India, most of the women wear sari, so the abdomen is exposed, so no incision is seen. So our women population loved it. And we have also seen that in children, since we can do with the small incision, they get little pain and they are also very happy. So since then we started doing robotic surgery in all patients who can afford it. Because in India, not every patient treatment is paid by the insurance. So they collect money and they pay from their pocket. So not everybody is
able to pay for
able
it.
to pay for the robotic cost, because in India if you do robotics they have to pay 1.5 lakh Indian rupees more, which is equivalent to like 2000 US dollar. So not everybody is happy to pay it. So those who are not happy to pay, they undergo open surgery. And those who can afford and pay, they undergo robotic surgery. Plus, if the patient is obese, we often get many obese patients, especially from the Africa, Central Asia, Fiji, and their BMI is 40, 46, 47.
Morbidly obese.
Very morbidly obese. For that, the robotic kidney transplant is a boon.
Yeah.
And we do the operation and they are very happy and they go home without any wound morbidity. And slowly our program has flourished, and now I can say that we have done the maximum number of robotic kidney transplantation in the world. Our number is crossing more than 450. No single center has done so many transplant.
That's been done in your center.
In my center. Plus we do all kinds of
robotic
robotic
surgeries.
transplant, whether it is a left kidney coming to the left side, left kidney coming to right side, right kidney going to left side or right side, second transplant, third transplant, orthotopic transplant. So we have been doing all kinds of transplant with very good results, and we have developed our new technique of doing it. We have done so many modifications with the existing technique which we have published, and with that I am now getting invitation to proctor the people all over the country. And now we have gone and done the proctoring in Switzerland. We got invitation
teaching other doctors all over
go
the
and
world.
show them how the operation is done, teach their doctors, train their doctors. Now I am going to Japan to do the teach the people to how to do the surgery. So it's very satisfying that I is not only doing the operation for my patient, I'm also disseminating this science skill,
sharing your knowledge,
and sharing the knowledge and training the other colleagues and friends, so that more and more people in the world can get benefit. So I would like to say that the robotic surgery is good because incision is small, no muscle is cut, there is no wound infection, recovery is good, painkillers are less. Next day patient gets up and start eating and moving around. There is no wound infection and there is no lymphocyte formation. And we have evolved this surgery, changed lot of things. We published it also. Now our technique has many modification, which is very friendly and cheaper than the other centers who are doing it routinely, mainly in Europe.
Besides cost issue, as far as the classical versus robotic surgery concerned, is there any other technical questions or factors that can influence your choice, or at least recommendations as to why you recommend or don't recommend robotic surgery? Is there any contraindications besides cost?
Yes, if the patient is thin, then probably robotic surgery will not make any difference, because in thin patient I can give 7-8 centimeter and at the most 9 centimeter incision and can do the surgery. So the patient who is very thin, I say there is no need to undergo robotic surgery even if they want, because if I do robotic surgery, your incision is 6 centimeter. If I do your open surgery, incision is 9 centimeter. So why to pay
Not
extra?
much of difference.
Not much of extra. And these thin patients do not develop wound infection and tissue wound morbidity is less. So there is one group of patient I usually advocate don't give, because I remember only last week there was a patient from Uzbekistan, and she's a young girl. She wanted to the robotic surgery, but she also required ABO incompatible transplant. So she required 4 plasmapheresis, and all the money has run out. So she did not have money to pay for the robotic surgery. So, and she wanted robotic surgery to be done. And she was very thin. So I said, okay, don't worry. I'll give a very small incision and do your open surgery. So we gave only 9 centimeter incision, did the surgery, operation went well. She's very happy. And now when she looks at the incision, she said, yes, thank you very much. You saved the money and gave a small incision. So that is the one indication where robotic surgery may not make much difference. And second thing, those who do not have money, I do not tell them to undergo robotic surgery, because these patients need money for immunosuppressive drugs. They need money for follow-up. They need money for further investigation. So it is better to save the money, undergo open surgery, do not undergo robotic surgery, and use this money for future
Medications
treatment.
and
So those who
follow-ups.
are financially not good, I do not advocate robotic surgery. In a very thin, I do not advocate robotic surgery. But those who are obese, and especially the morbid obese, I do recommend robotic surgery. In young female, I do recommend robotic surgery. And children above the age of 25 kilos and 10 years who has enough space in the abdomen, I do advocate robotic surgery, because all these patients, their morbidity is cut down, their pain is cut down, their analgesia requirement is cut down. There is no wound related morbidity, and they recover very fast, and they are quite happy about it. And the result of open surgery and robotic surgery are same, because once the kidney is dropped in the abdomen, the rest of the procedure is exactly the same. So the functional outcome, whether you do open operation or robotic operation, is same. So I always tell laughingly, if the person asks many questions, I say, from here to airport you can go in Mercedes car, or you can go in a routine any car like Maruti car or any small car. You will reach to the airport.
Yes.
But with the Mercedes car you will be more comfortable. But for that comfort you have to pay more money also.
Yeah.
So the people understand this kind of analogy. But it's not that open surgery is out. Open surgery is still a very good surgery. And my 70 or almost 70% patient undergo robotic surgery as open surgery. 30% undergo robotic surgery. Open surgery is the gold standard. The open surgery is being done for last 75 years. I have been doing open surgery for last 40 years. So open surgery is excellent. It is gold standard. But it is associated with the big incision and retraction and pain and morbidity and wound infection. So if one can avoid it, then robotic surgery is good. So I don't say open surgery is bad. Open surgery is gold standard. But in obese patient, wound morbidity is, especially if they are diabetic, if they are obese and they are immunosuppressed, and they are obviously on dialysis for long, so they are not in a very good health. So these people do double wound related morbidity. So where robot has a edge over the open surgery.
Yeah. And this surgery, you talking about only the patient's perspective. So you've been doing this donors and the laparoscopic kidney removal, right? Nephrectomy.
Yes.
So does that matter as far as robotic or versus classical surgery concerned for the donor?
Yeah, the donor, I have not done open donor nephrectomy since 2002.
2002.
All my operations are laparoscopic. The donor can also
23 years.
Yeah, donor can also go robotically, but there is no advantage, because
You already do laparoscopic.
laparoscopic will have same 4-port, robot will have 6 ports. The time taken will be the same, magnification is same, wound again will be retrieved by because kidney has to come out in intact. So that wound incision, 6 centimeter incision has to be given. So there is no advantage of robotic surgery in
For
donors. So till now I have done only 2 donors the robotic surgery by robots. One patient had a horseshoe kidney, and that was a very complex thing. I need ICG, I need identification of vessel by ICG and multiple vascular clamping. So I did use the robot. That was the first robotic donor nephrectomy in horseshoe kidney, and this has been published. Nobody has done before that, and that was very successful. When I showed it in Europe and in America. They were very
They're
happy,
applying the same technique
and they
now?
have published it.
Mm.
So, and in one conference, I showed how you can do the robotic donor. But otherwise, I don't do it. It is possible, you can do it. It is simpler. But then you pay extra cost. So what is the fun in doing it? It is like in a same plane, you can sit in economy class and business class. You will reach at the same time and same
From A point to B point.
A point to B point with the lot of difference in the cost. Robotic surgery is also very friendly to the doctors. When I do open operation, I stand and I have a headlight and I have a magnifying loupe and I stand and keep doing operation. In robot, I sit on a chair and the robot comes to my face and I sit and do the operation with lot of ease, so I am not tired after the operation. So robot is not only good for the patient, it is very friendly to the doctors also. So it also increases the lifespan of a doctor, that he can do it operation for longer period. There is one more advantage of robot. Suppose the doctor in old age develops some tremor.
Tremor, yes.
And while he's doing open operation, his hand is shaking, he cannot do the operation. But if he sit on the robot, even if his hand is shaking, the robot will filter all his tremor, so that when instrument is doing operation inside the abdomen, there will be no tremor. So the doctor will still be very precise even if he has got the tremor. I don't have tremor, but I'm just saying that
yes,
robot
increases
the life of the surgeons also.
To summarize, as far as the robotic surgery is concerned, that's possibly is going to be future, right?
Yeah, actually I was very surprised. I was in America in April for American Urology Congress. And then they were talking only the robot, not laparoscopic surgery, especially the donor nephrectomy. So I got up and asked them, what is the advantage of robotic donor nephrectomy? Why you are talking about this? You are paying extra, you are putting more port, you are taking more time. What is the advantage? Why you have stopped doing laparoscopic donor nephrectomy? I asked them. Then they said, oh, we stopped laparoscopic surgery. Now we have, all our theaters have robots. So we are doing all robotic surgery. We are not training our residents of laparoscopic surgery. So there is no point in talking about laparoscopic surgery. So we all switched to the robotic surgery. That's why we teach, that's what we train, and that's what we do. So laparoscopy has stopped in America. So I was surprised, but I see laparoscopy still is a good future in India because it is cheaper. And it is still
readily available.
Because
not all centers can afford the robot yet,
yes,
right?
but the laparoscopy can be done in most of the operation can be done laparoscopically.
That means the Indian surgeons and urologists still being trained do the laparoscopic procedures.
But laparoscopic kidney transplant is not possible. It is possible, but very difficult and maybe not very safe. Because one doctor in India, Dr. Pranjal Modi, has started, but then he also stopped it.
Because of that technical difficulties.
Because of the technical difficulties. It is possible, but there is a lot of technical difficulties.
Other than transplants, you do lots of urological surgeries, like you said, the cancer surgeries, prostatic cancer, everything. And the robotic surgeries can be used for all of these problems.
Nowadays we are doing a lot of surgery either robotically or laparoscopically, like pyeloplasty, ureteric renal implantation, ureteric stricture, bori flap, bladder augmentation, neobladder formation, ileal conduit, renal cyst partial nephrectomy is one of the most common operation done. Radical prostatectomy, radical cystectomy, retroperitoneal lymph node dissection for testicular tumor, inguinal lymph node dissection, pelvic lymph node dissection, plus any kind of reconstruction in the abdomen is now like rectovesical fistula, viscovaginal fistula, ureterovaginal fistula, rectovaginal fistula, viscovaginal fistula, all are being done with the help of robot. So that robot has expanded its indication, it cut down the morbidity, it makes life of the surgeon is easy because he's sitting and doing the operation, he's not tired, and patient get very precise because in robot you get 5 times magnification. Your hand movement are 7 times, and even you can go anywhere deep in the pelvis with the camera, which my eyes can't reach. My hand can't go in the deep in the pelvis. to do the operation because my hand needs some space.
Articulation also easier in
easier.
robot, right?
Has 7 times articulation. My hand has a 6 time articulation. My hand needs space to go there. Robotic instruments are finer and small. They can reach there anywhere in the pelvis. So that's how the operation becomes very precise, very accurate, and there is less blood loss or no blood loss, and tissue looks very good. Tissue handling is very good. So that's how the robot has become so popular.
As far as cancer procedure, surgery concerned, you're doing the cancer surgery, right? The visual inspection is going to be easier as well, right?
Actually robotic has no haptic feedback, like you can't feel. Everything is done basis of what you see.
Visual.
But the latest robot is coming with the haptic feed also. The newer models are coming. But now in last 25 years we are so tuned to do everything by
Visually.
the vision. So I don't know that how much haptic feedback will be useful in future.
But my question is this, like in your hand, you may feel the feedback, right? So where is that important?
Yeah, it's important. Like we have been trained to feel. Feel is a very important, touch is a very important sensation for the doctors. I can touch and I can say
softness,
it. It is softness,
on the
hardness, tenderness, soft fluctuation. So I can feel it. But in robot it is not there. But by vision we know what it is because of the experience and all that.
That could be one disadvantage of robot,
Yes,
right?
but the newer robots are coming with the haptic feedback.
Oh, they can touch this tissue, soft
And
tissue, and
then
tell
you
you.
get a indication that whether it is soft or whether it is hard or what, how much resistance it is showing. So the technology is evolving.
So my question is this: since you have been doing this renal transplantation so much in high numbers, my question, as far as patients concerned, what are those misconceptions among the patients that they don't?
Yeah,
they realize late.
Yeah, it's very interesting. Many times patient comes and say, "Doctor, we trust you. We don't trust computer. So we don't want robot to do our operation. You do you do my operation." So I laugh and tell them, this robot is master and slave device. It's not that I say robot start the operation, robot finish the operation. No, I sit on the console and my hands move. As my hands move, it like when you play the video games, as you do change the joysticks, the movement happens. So same way there is a joystick and which is entangled in my hand. As I move if I do this way, the scissor will cut. If I do this way, the needle holder will come. So that way the instrument moves as my hand moves. And there is a scale of movement in my hand and movement of the instrument.
It's your extension.
Yeah,
basically.
So make everything good. So still this current robot is a master and slave device. Robot is my slave and I am the master. So I have to sit. If I just look other way, robot stops. So robot will not do anything unless I ask robot to do something. And when I ask do the robot thing, then robot do it very precisely and concisely and in a perfect way. So that way robot is a very good slave. It's not the master. I am still the master.
Yeah.
But in future it is being planned that you will feed all the data and robot will have all the information. Robot has data of thousands of patients.
Artificial intelligence.
And artificial intelligence. So when you feed all the patient parameters and you start the robot will finish the operation. But that is probably many years away. But that may happen in future. It is being worked out. People are working on it.
So that is the misconception that patients think that if you do robotic surgery, your involvement is lessened.
No, my involvement is 100%.
100% you're involved.
But there is one operation has evolved, which is known as aquablation. Aquablation is done to treating the benign prostatic hyperplasia, benign prostate, in which the doctor puts the ultrasound, doctor puts the cystoscope, doctor measures everything and mark everything. And when all the marks are put, boundary is drawn by the doctors, by ultrasound and by cystoscope, and it is fed to the computer, and then doctor pushes the button. Now doctor is standing there and operation is done by the robot and it finishes the operation in 20 minutes. So that is aquablation, that is complete robotic operation of the prostate. It is not available in India, it is done in Europe and America, and it's very expensive. But that is the one operation which is completely done
Autonomic
with
done.
what all the data is fed by the doctors.
My question is this: is it required still doctors should be looking at it?
Yeah, currently yes, because there is two persons' face is not same.
Exactly.
There is no person exactly like you.
Yeah.
Same way that two person behave differently.
Everybody is
Their
individual.
disease is differently. Their tumors are differently. Their anatomy is different. So you need individualized treatment for every patient.
So your involvement is 100%
Yes.
at this point.
Yes.
Like since you do lots of renal transplant procedures, what would you like to tell these potential patients or whoever facing that problem and having trouble to understand the situation, or what's the misconception among those patients? What would like to convey those patients?
Yeah. See, we get patient transplant patient from all over the world, from Central Asia, Southeast Asia, from surrounding nations, and mainly from Africa. And and they get all kinds of problems. Some of the patients are very difficult. They need second transplant, third transplant. They have very complex situation, multiple vessels, and they might need some operation before it, reconstruction before it. We do the transplant. Their bladder is not good. They may need bladder rehabilitation before the transplant is done. But what my message is, nowadays kidney transplant is a safe operation. It is possible to do in almost all cases, unless patient is not going to live for long. Then there is no point in doing kidney transplantation.
Life expectancy.
Yeah, if life expectancy is not much. So when patient comes, we do all investigation. We study the donor and recipient. Then we sit down and discuss it and plan the operation. And most of the time operation is successful. But something is not in our hand, like rejection. Even though we do all the investigation beforehand to avoid the rejection or match the kidney perfectly or desensitize the patient, give immunosuppression to suppress the rejection, but still some patient we get rejection. And then they
Very small percent,
it's
but
very
it's
small
there.
percent, but it's still there. We have not been all over the world, they have not been able to eliminate rejection completely. And then when you treat the rejection, some of the people do get infection. And later on, some of them get malignancy also because body is suppressed. So these problems are still exist, but currently the renal transplant success rate is very high. 2 years survival is 90%, 5 years survival is 80%. Most of our patients have 60% patient live, the kidney lives up to 10 years. And we have many patients living to more than 25 years, 30 years. My last patient done by me is now crossed 34 years. So
with the first kidney.
Yeah, with the one kidney. So the results are very good, but they need very regular follow-up. They need monitoring of their kidney function for infection, for malignancy, for drug titration. So all those things are required, but if they remain in close follow-up, they take the medicine regularly, they take care of themselves, then most of the kidneys do well once the initial period is over and rejection part is gone.
Yeah, there is one more misconception that patients come to me and ask this multiple times. So I would like to answer you this question. The donor's risk, life expectancy, quality of life after being, let's say during the being donor and then after being the donor.
Yeah, it's a very good question. Actually, it's a very important question. And I thank you for asking this question because donor life is very important. This is the one peculiar condition in medical science where somebody is undergoing a major surgery to help others. Otherwise, you undergo operation, you have a gallbladder disease, you have heart disease, you undergo operation, you become all right, you benefit from it. But the donor is undergoing operation for none of his benefit. So it is our job to make sure the donor should not get any complications, should his life is not in danger, he should live happily after the kidney donation. So what we do when the donor comes, we do very thorough investigation. We check his heart, we check his liver, we check his lungs, we check his both the kidney, we check his diabetes, we check his any other disease. If they have it, then we put him in the optimal condition, and then we take the kidney out. And now approximately there are almost 10-15 million people who have donated their kidney all over the world in last 30 years and lived happily 20, 25, 30 years after that. 1 in 300 patient donor may get into the problem. Like there is a very nice study published in America. They followed 10,000 patients for 25 years and they have seen there was 93 patients who developed some kind of kidney problem. Few required kidney transplant. Few have lost their kidney and required dialysis. But when they have gone and seen that, they have seen that they also have some genetic predisposition for kidney failure. They had some genetic problem which was not detected at the time of donation.
It was not necessarily because of they've been donors.
Yeah,
before,
so
right?
they would have developed renal failure even
Anyways.
if they have not donated the kidney. So 1 in 300 patients do develop. I have done more than 5,000 transplant. Till now I have done one donor who has given kidney to the father and 7 years later he developed renal failure and last year I did his transplant. So he first gave kidney to his father, now he got the kidney from his brother for the transplantation. And there is one more patient who after 5 years of donation he started developing glomerulonephritis. So he had some genetic predisposition. So there are some patients who develop the problem for this. So
but it's a rare situation.
But it's a very rare situation. I don't say that there is no risk at all, but the risk is 0.003%. Very low. And there are a lot of patients. So when the donor is apprehensive, I ask them to meet the people who have donated the kidney. So when they talk to them, they get confidence. And I salute the donor because you need lot of courage to donate the kidney. Even if I ask you to get an injection, you feel scared. Here you are undergoing major operation. If I ask to give me $100, you will think 10 times to give
twice,
me.
yes.
Now I'm asking kidney.
Yeah.
So that guy who is giving
it's
kidney
no small decision.
It's not a small decision. He's a great guy. He's doing it to save others. He's undergoing pain, discomfort, operation. So donor is a real hero.
Yeah.
And so we should make sure that he should not suffer.
Yeah. Another question that most patients ask me specifically is that after donating, am I going to be all right? Or am I going to be disabled or something is going to be wrong with me?
It's a very question. Most of the donor ask this. Only thing you cannot do, you cannot join the army, you cannot join the police force, you can't do the airline pilot or railway pilot.
Or
otherwise
fly to space.
Or you can do it anything. Because one kidney is more than enough to live happily.
Yeah.
There are many children born with the one kidney and they die after 70, 80 years without knowing that they have one kidney.
Yeah.
So that one kidney is good enough to lead a happy life. After many donors, they can have baby, they can marry, they can do horse climbing, they can go to the mountain, they can do anything they like.
The healthy person can do.
Yeah, but there's nothing restriction is there. But we tell them not to do contact sports like rugby and soccer playing.
There is a possibility of trauma.
possibility of trauma to the one kidney, then you have one kidney. And do not take any medicine without consulting a doctor because some of the medicine like aminoglycoside, NSAID, painkiller can damage the kidney. So don't take any medicine without asking the doctor. If there is tell the doctor you have one kidney. And be careful, that's all.
Yeah. Be careful from the diseases or medications that may harm your kidney.
And if you are not well, go to the doctor. So they will be taken care of. And most of the donors do very well.
Yeah. Thank you very much. And last, to sum up, that what is your advice is going to be for the upcoming young doctors? Whether they choose the urology, if they are, thinking about it, or if they want to go to the robotic training, what is your advice is going to be to them?
See, my advice is do whatever your heart says, whatever you like, what you want to do it. It is your life. You do it what you want to do it. But robot has come here and it is a stay. Next 10 years, every theater will have some kind of robots. There may be different types of robot because there are many companies are coming. They'll come. And almost most of the procedure will be done with the robot. So if you are joined the urology, you have to learn the robot. You cannot And
avoid
robotic will not be only for transplant or for the oncology. Robotic will be done for almost every procedure.
It's going to be universal.
So robotic is like one of the skill you have to practice the urology or surgery or anything.
So that means in the future, for the surgeons, robot is going to be unavoidable.
Yes.
At some point, it's gonna
It is one of the tool which we need it to deliver a very precise medicine.
And another interesting question, like every new thing, innovation is coming to the medicine. Let's say in the laparoscopic surgeries, like whoever was classical open surgery doctors, they initially didn't want to accept the laparoscopic surgeries in the past, if you remember that, right? So the robot is coming, and some surgeons could be avoiding the robot.
There are some hesitations, some are not doing it, but now everybody is realizing that this is inevitable. We have to do it. We have to take it. I tell them, the train is leaving the station. If you don't board it, you are left.
You're gonna stay behind.
The train is not going to stop it, and train will move.
Okay, thank you very much.
Thank you very much
for agreeing to
and asking some interesting questions which will benefit the patients. And I hope this podcast will help patient to understand and take a decision.
Thank you very much.
Thank you.